Hi, I'm Jasmine, creator of The Curious White Coat, and I'm back with another rotation recap video. So, my third year of clerkships really put me through the ringer. Like, we were supposed to start in March of 2020, but we all know what happened around the world at that time, so everything was put on hold, and we ended up just going through months and months of virtual learning that just made you want to throw your laptop out the window, and you'd have like zero regrets about doing that. So finally, on one wonderful morning in August of 2020, I was able to have my very first official in-person third year clerkship, and that was in family medicine. So this video is going to be all about the family medicine clerkship and how you can prepare for that rotation and the shelf exam. I wanted to start with some background before we got too deep into the video. So family medicine is a type of primary care specialty. This is what a lot of people think of when they imagine like a trip to the doctor's office. But the setting of family medicine can actually vary. So a lot of us think, okay, it's my PCP or my general practitioner, but family medicine trained doctors can also work in urgent cares, they can work as hospitalists, and in other roles outside of the doctor's office. So family medicine is a required core rotation by the LCME in order for medical students to graduate. It's typically like 8 weeks long, but that can vary depending on your medical school and what they have in store for their curriculum. I will say though, this rotation really hits every organ system. So if you have any power over your schedule for third year, I would try to take family medicine early on. It really helps you to get a real-time application of everything you've learned in the past 2 years. Plus, all of that knowledge is still fresh in your mind, so it kind of makes the rotation easier. My typical week was pretty busy in this rotation. So on the weekends, I would try to get in most of my studying because there wasn't as much time during the week. But on Sundays is when I would kind of reset. So that's where I would do my grocery shopping and laundry in the morning. And then in the afternoon, towards the evening time, I would study and then prep for the week. So Monday morning, I would wake up around 7:30. I'd get ready to go to clinic, and then on my drive in, I would listen to different podcasts like by the American Academy of Family Physicians or Emma Holiday videos on YouTube, and then I'd get to the clinic around 8:30. And getting there early allowed me to be able to pre-chart with some of my other fellow med students, and we would look at all of the appointments on the list and try to pre-populate the charts with as much information as we could, so that it'd be easier when we were doing note-taking later on that day. But clinic started at 9 o'clock, so when the first patient came in, we would take a patient, go to a room, you would get your history, your physical, you'd try to come up with a differential and a plan, you'd present to the patient, to the attending, you present to the attending, and then you would go and discuss your plan with the patient and do any other interventions that may need to be done. So that was what you did pretty much all day. Lunchtime was around noon, 1 o'clock. We would stagger when we would eat lunch. And then clinic ended at 5, but sometimes it would take me a long time to write my notes, especially at the beginning. And sometimes I'd leave at like 7, I think was 7:30 was like my latest time. But that got better as I got better at note writing. So I'd get home for sure around 7, and then I would eat dinner, study some more, and then just crash by 10 o'clock. To be prepared for this rotation, you're going to want to have your own stethoscope, something to write with, and something to write on, whether that's paper, pencil, or something electronic like an iPad for you. Just make sure that you have that. For the most part, everything else that you'll need will be in the patient room. So the otoscope, the ophthalmoscope, all of that will be in the room. This site was pretty nice. We had dermatoscopes to look at different rashes. We had monofilaments for that sort of test. So pretty much everything you'll need will be there. If it's not, just be prepared maybe to bring your own, like, I don't know, blood pressure cuff or reflex hammer, but everything should be there. As far as what you'll wear, that's going to be attending dependent, so you can ask like a week beforehand. I just erred on the side of wearing business casual and a white coat on my first day, and the attending, when we talked about it, he was like, oh, you can just wear scrubs. So that's how we kind of played that. I think it's better to be more dressed up than underdressed. So that's like not really as big of a deal. As far as common diagnoses, there are so many things that you see in family medicine. Literally everything in life can come through that door. So to say common is, I don't know, it's just probably not the best approach. You should really just be prepared for everything. But I'll try to have some of the common diagnoses go across the screen. So there's a lot of cardiovascular concepts. You're going to have patients with long-standing angina and heart disease, people with history of heart attacks. Be very familiar with hypertension and know how to take a blood pressure on your own manually with the stethoscope in your ear, the blood pressure cuff, know how to take people's vital signs, how to put a thermometer underneath someone's tongue and, press the button so it takes the temperature for you. Be familiar with all of those things prior to coming in. As far as respiratory concerns, we saw fewer of these because at the time COVID was still fairly new, and we weren't allowed to see patients who were COVID positive or who had symptoms of it. So cough, fever, all that stuff we didn't see. But those are things that commonly come in, especially as you get into the winter months where everyone gets colds and the flu and all that stuff. Other things we saw, you're going to see a lot of chronic issues, people with chronic kidney disease, different types of stomach problems, someone who's coming in because they've been constipated for a long time or having diarrhea for a long time. So you'll see a lot of different things. Also be familiar with commonly used medications, the antihypertensives, lisinopril, all the sartans. Know the names of those because everyone's going to come in and they're going to say names by the generic, by a brand, and you have to look it up. So try to be familiar with that, and also know about the different antibiotics and when to give them and when to not give them. There's also a lot of art in communicating to people to explaining, like, this is why we should not prescribe antibiotics, or this is why we choose to go on this certain path, and make it a group conversation, because it's not just about the doctor telling the patient, oh, you should do this and this and this. Like, you want to come to a consensus with each other and make sure that you are able to give informed background so that the patient can give their informed consent to things. Everyone always wants to know about study resources, so here it is. My two favorite resources were the board review questions from the American Academy of Family Physicians and using the practice NBMEs. Nothing beats a good practice question, in my opinion, as far as preparing for an exam. And the AAFP questions were honestly extremely relevant, like right on target. There were questions that I would not have gotten right on the shelf exam if I hadn't have done those practice questions. And of course, the practice NBMEs are going to be imitating the shelf exam itself. So those are good to do. Also, for like your daily stuff, you can read Step Up to Medicine. That is a very good book for family medicine and internal medicine. It has a section in there called Ambulatory Care or something like that, and that is very specific to family medicine, so I would read that. And also read the Social Sciences Medical Ethics section in First Aid. Everything else, I would say, was pretty much ancillary tools. Even UWorld, and I don't say that about UWorld a lot because there was no specific question bank for family medicine. So I tried to take like a combination of IM questions and PEDS questions and OB-GYN and use that on random, like mix those up on random and take that for my UWorld questions. But it didn't have a specific bank, so I didn't really put as much emphasis on it as those other practice question resources. And case files was good too, but as far as the other resources, like I'll put them up there for you to see, but I really liked those others with the gold stars on them. You take a shelf exam at the end of every rotation. So for family medicine, I took mine on the last Friday of that 6-week period. So I would take all of my study resources, all of the practice questions, all of the books I was going to read, and I would divide up the pages and the questions over the span of 5 weeks. And then I would have that last week to just do review of any of my deficits that I had noticed over that 5-week span. And I would also do practice questions. And that's all I would do for that last week. And then actually the day before the shelf exam, we would get off from our clinical duties. So I'd use that to kind of study and then take a break for like the rest of the day before the exam. So as far as content, you can get content outlines from the NBME. The one that I saw for 2020 at the time was very heavy on cardio, respiratory, and GI. But I will say every topic is fair game in family medicine. Like I've been saying, you hit every single organ system in this rotation, and the exam is really no different. I will say there were fewer straightforward vaccine questions for my version of the test. I was expecting a few more. But also don't forget about your social sciences and medical ethics types of questions. There will be quite a few of those on the actual shelf exam. And I will say for that, communication is always number one. And be honest with your patients. Like those are always the right answers when it comes to those questions. And some of them are pretty straightforward, like are you a good person or are you a jerk? But then some of them can be kind of hard. So just kind of try to follow that ideal, you know. And it's true, like you always want to communicate with your patients because you're not just doing this at them, you know, it's a team effort to make sure that everyone is healthy. So that's just something to keep in mind. The medical student role can really vary depending on your attending. Luckily, at this site that I was at, we got to do everything. He wanted us to see it all and do it all so that we could understand it before we were doctors. Sometimes you can get kind of pigeonholed into one spot and not see other people's perspectives. So I feel like we really were able to see it all. And I think that helps you better understand things when you are a provider, like an official provider. So, we took patients from the lobby and did everything with them. So I was giving flu shots, EKGs, pulmonary function tests, and learning how to actually like read the stuff too. Looking at rashes underneath the dermatoscope. We screened every patient with a PHQ-9 for depression, and we addressed those things. So we saw a wide breadth of issues, and we learned so much. And I realized that I actually loved the outpatient setting more than I thought I would coming into medical school. I thought I'd really only want to be like in the inpatient environment in a hospital, but I really enjoyed this rotation, and I had some of the best patient interactions here out of all of third year. So it was a great experience, and I felt like I was really like a doctor. Just a few takeaways to end this video. I would say try to get good at writing your notes. That way you're not holding up your attending and you can get out of there on time. Be willing to try everything. By saying yes to so many things, I was able to learn so much during this rotation. And also use this time in your rotations to try to understand the healthcare system as a whole. I think that really helps us to understand our role in the future as doctors too. I will say family medicine is a great rotation to start off your clerkship experiences. It has something for everyone in there, and you go through all of the different fields. There were times where I was talking to patients who had suicidal ideations. I was working up whether someone had seizures or syncope, and you were able to come up with solutions for all of these things, and you get a good amount of exposure to everything. Family medicine really holds it down for all of us. Like they are part of that first line of prevention to make sure that everyone stays healthy, and you can really do some good by going into that specialty. So that's all I got for this rotation recap video. Check out my other videos so that you can learn about the medical student experience, and don't forget to subscribe to The Curious White Coat. I'll see you later. Bye. There are also some pretty interesting things that you encounter on this rotation. So I had a patient that was quite the talker. I would try to get like just a word in because I was trying to be very cognizant of not being that doctor that interrupts the patient within those first 10 seconds. But he would just talk and talk and talk. And I was like, I don't even know how to redirect the conversation at this point, because I would start talking and he would just talk over me and he would go off on tangents. And I was like, oh boy, how do we like regroup and get back on target? It was quite crazy. And then I had a scary situation that happened. So there was a patient with a history of a heart attack. I think he also had high blood pressure. I don't remember his other medical history. So he had come in because he works a lot with his hands. It was either for a hobby or something like that. And he was having like a lot of pain in his hands and he wanted to get that looked at. He thought maybe he had like arthritis, like an osteoarthritis. So we're talking about that. But then he mentions, I think it was when I was going through like the review of systems, he mentions having had chest pain in the past couple of weeks. So I'm thinking, oh, well, you have a history of a heart attack. Let me get some more history on that chest pain. So he starts describing it as this chest pain that is provoked by when he's walking, when he's stressed. Sometimes it goes down his left arm and I'm like, oh my God. So I'm asking him like, wait, are you having that chest pain now? And he told me no, but I probably asked him like 4 or 5 times, like, what about now? Like, are you having pain now? He started to get really like annoyed with me actually by how much I was asking, but I was like, I don't want you to be, in the middle of an MI while we're talking about your hands. But that was his main concern, was his hands. So he was kind of like, why are you not listening to me? So I had to explain to him the concern and like the gravity of the situation if he was having a heart attack. So my attending was like, let's get an EKG. And we did. And then we compared it to an old EKG. But at the time when I was doing the first one, I was like, these Q waves, they're looking a little wide. I can't remember everything from my virtual didactics from COVID, but I think that's a left bundle branch block. So then go compare it to the old one, and then here's this new finding, and then the attending confirms it for me. He's like, yeah, that's a bundle branch block. And I'm like, doesn't that mean he could have had a heart attack in the past? And so now we're both asking him like, are you having chest pain right now? And he wasn't having like any issues at all. So I think he ended up like taking an aspirin and seeing a cardiologist like literally like within moments. Like that's where he went next to see the cardiologist. So he ended up being okay after like I asked about him afterwards. But that was a scary moment because I remember seeing that EKG printout and I was like, question. So there was that. I also had an interesting story where this was like a shame on me moment. I should have known. There was a patient who had come in and her complaint was that her urine was hot. And at first I'm like, what? Is that a thing? I didn't know that was possible. And I thought maybe she meant that it was just burning, like a UTI or something. But I got as much history as I could. And then I go to present to the attending and I was like, her main complaint is that her urine is hot. And I'm like, I don't fully understand. But then he said, well, what's your differential? And I told him and he was like, did you consider urinary retention? And I'm like, oh. And then he explains to me how with the urine not exiting the bladder, it sits in your body, which is a nice toasty 98, 99 degrees. And it basically is just baking in there so that when it finally does come out, it's going to be hot. Because I mean, when you're in your room, it's like what, low 70s? So it was definitely a very real thing. And I ended up doing a pelvic exam on her, the very first one that I had done on a real patient. And turns out she had a cystocele. So that was definitely a new learning experience for me. Definitely keep an open mind, when you are a medical student, and listen to your patients.